Oh, thank you for the invitation. Thank you for being here again. I'm very happy to be in Vietnam for, I believe, the 12th time, and not so long as Birgit, but we know very well your friendly atmosphere here, and I really profit of that. I hope that my slides will work. It works. I see. Okay, wonderful. So this is a combined action here now from the Vietnamese National Heart Association together with the German Vietnamese Federation of Cardiology, and I really like to be here. The next is that I have to talk about how do I detect diastolic heart failure and primary congestion using echocardiography. This is your fault. You gave me this title because diastolic heart failure in general is understood today as diastolic heart failure and heart failure with preserved ejection fraction. You all know that, and I have thought it over, and I have asked you last night if I can talk about diastolic heart failure and primary congestion. I will tell you why I will change my title a little bit, because the newest guidelines are in this direction. So I have exactly 15 minutes. I'd like to talk about that subject hours. Okay, we started with diastolic function analysis very early. In 2007, we had the first article written on diastolic heart failure with normal left ventricular ejection fraction. This was hardly discussed afterwards with Liv Hutler, and she did not want to have this insertion of preserved ejection fraction, but this was not the last article. Then we had another article which was done by cardiologists. The first is not cardiologists, the first were for pharmacologists and whatever who have done the job. And then this was Nagy, who is one of the leader in diastology still today, and J.O. is the other leader of, and we have Frank Flachs, who have done a lot of Doppler echocardiography before. Okay, but this was in 2009, and then Frank Flachskamp has published this wonderful paper on how to image diastolic function by echocardiography, and he has, this was not the last paper, but this was finished by the guidelines which were published in 2016, and this is the same group. We recognize all the same authors, and then this is the newest publication just now. It was published, and it is interesting to know, for you at least, that not only my title is like that, but ventricular diastolic function by echocardiography and for heart failure with preserved ejection fraction. We cannot avoid today to talk about diastolic function if we do not talk about HFpEF, because there are lots of people who have exclusively talked about HFpEF, and this is not the topic of diastology at all. So we go through it. And we have very early already started in 1987 to talk about diastology, and we saw with all our echo images and echo machines that the earliest phase of diastology was the inflow, and we could really look for the inflow very nicely with color mode. And at that time we thought that with color mode we have a certain idea of what the relaxation of the ventricle could be, and at that time we thought that this would be an ischemic parameter. This was not true, but we know of course that still today, and this is renewed again with the new recommendations, that we have to differentiate between the relaxation and the compliance or the stiffness of the ventricle. And what we are talking about when we are talking about diastology in hemodynamic terms, this is the mean atrial pressure, or this is the relaxation constant, or it is the parameter of stiffness compliance parameter. These can be measured only by cath lab, or we can try to approach the ideas by echocardiography, and I will talk a little bit more about that. Okay, so that what we saw in the beginning was very early, already in 87, that the inflow, which is directly reflected by Doppler across the mitral valve, is E over A, and if E is smaller than A, this was a slightly form of diastolic dysfunction. Prolonged relaxation, we thought that it was the only reason for being a smaller E wave, and then we could not differentiate in these patients if this is normal or pseudo-normal, but we know exactly that if there are normal conditions all around, then if you have only a high E wave, you could be very sure that this would be more or less a question of restricted filling. Okay. Sorry. Okay. Sorry. The next is that we had this recommendation for the elevation of left ventricular diastolic function, and in very early times already, we knew that the first E wave is not only question of relaxation. It's a question of the pressure inside the left ventricle. And if you have a higher pressure in the left ventricle, then the valve opens earlier and it will be steeper and it will be higher. So if you unload the ventricle, and this is still in the newest guidelines because everybody has denied it before, but in the newest guidelines it's again expressed that if you do a Valsalva maneuver, for instance, or you lift the legs on the other side to increase the pressure inside the left ventricle, you can simulate different volume loads to the ventricle, and this will directly change the aspect of the EA wave, and this is wonderfully shown in the first paper here, Valsalva maneuver. This looks very normal, and then you make a Valsalva maneuver and you see what happens to the E wave. So this is a very simple experiment. And now, after a certain time, there was the story of the tissue velocity imaging. Tissue velocity imaging was, first of all, thought to be a better way of visualizing the signal-to-noise ratio in echocardiography. This was George Sutherland who has invented that, but that did not work at all. But then, as one application of the system was that you can measure the velocity at the edges, when we normally do it today for the septum and the lateral wall, and you see the velocities. And then it was obvious that if you have such a normal appearing diastolic inflow with the mitral valve, you might have in some patients reduced E prime and A prime, which is larger than. And then we thought that this would be a very good idea to calculate with these different aspects the E over A ratio, and then at the same time we could perhaps calculate the E over E prime. This is what we can do with our machines every day today, that we can calculate that, and we have thought at that time that it could be a solution to work with E over E prime as a diastolic function parameter. And then it was described, and this is very early already from 87 from my side here, that we have these parameters. Oh, sorry, I must go back. Oh, sorry. Okay, we had these parameters, and this is still in the literature of the world, that if you have less than 8, it is normal. If you have between 8 and 15, E over E prime, it can be judged with some more parameters, and if it is more than 15, it should be elevated mean pressure in the left ventricle. We thought at that time that it could be possible to differentiate PCWP, or left ventricular end diastolic pressure, with these two different measurements, and this was repeated by any other authors afterwards. But we must go back to the original paper in 2000 from the Mayo Clinic with Tajik's work. This is the only work in the world who has really shown and tried to find with receiver operating curves parameters that could simulate the left ventricular end diastolic pressure. And this is very, very bad, and the correlation here. And the best of all these bad parameters was the E over E prime. But in this group, there were only 4 patients with an ejection fraction of more than 50%. So this is the basis of all we are discussing today. There are no new parameters we have ever been done afterwards. So then this is this paper of Flaxkampf, and he showed us very nicely that that are different things that could be judged when we are looking in echocardiography for the Doppler and the movements and the velocity time integral and so far. And this is extremely interesting to see this in details. But one thing which is really very important is that the E waves from the septum, the E prime waves of the septum and the lateral wall are extremely changing with men and women and extremely changing with age. So there is no standard parameter, as I told you before, between 8 and 15 and more than 50. You cannot really believe that this is correct. What my understanding and what the understanding of the world right now is that you have a lot of parameters that you could look for in diastology. It is not only one parameter. We are using all these parameters now. This is a strain analysis of the left ventricle, you know, strain, global strain, whatever, regional strain, post-systolic shortening and so far. Since some years now we have the left atrial strain. This is a little bit critical because many people think that this is exactly the mirror image of the left ventricle. We should talk about that in a minute. Then we have the color emerald, as I told you before. We must look for that. And we have, of course, the normal flow across the valve, and we have the lung vein flow. And the idea behind all that is that we differentiate the 3 phases of the left atrium, which is that key event for diastology today in differentiating the reservoir strain. We have the conduit strain and the booster strain. It is not time enough to really explain everything, but it is obvious that there is some passive filling of the left atrium, then there is active filling, and then there is an intermediate filling. We see this in all our patients now. What we can try to understand is that relaxation and compliance of the left ventricle can directly be seen here by the strain analysis. We have all these other parameters, and we can at the same time look for force and compliance of the left atrium, which is extremely interesting, and size and mechanical dispersion of the left atrium could in some idea be interesting for atrial fibrillation patients. I must go on, and this has been directly shown with Professor Vogt, who has been very critical against the left atrial strain, but he has shown very nicely in his comparison work of this year. It has been published this year, and without going too much into details, I can give you only the results of what he has found out. He has thought that the events that happen to the patient, MACE, everybody knows that, death, and everybody knows that, but even if decompensated heart failure arrives, the only parameters that are really relevant and have the best predictive value are the left atrium parameters. And all the parameters are enumerated here. You see it, sorry, you see it here. It is reservoir strain, you see, oh, sorry. Sorry. You see the reservoir strain, coronary strain, contraction strain, and all these parameters have much better predictive value than that what we can see from all the other parameters. Okay, so we're going to go on. And the recommendations of today have a lot of application dealing with the pressures in the left ventricle, but they try to find out with a lot of these parameters. We have not told about everything of that here now. And at the end, they show us that these are the parameters that you should find out by high sensitive pressure measurements in the left ventricle, and these are the parameters that you could find by echocardiography. It is not time enough to go through all these parameters, but it is obvious that it is not equal to each other. You must really try to combine several parameters, and it is, in my eyes, it is not really too complicated to understand that. What is really new in the guidelines is that there are normal values for all these parameters that we are measuring, and this is, in terms of quality assurance, it is extremely important that we correlate all what we find with parameters to the age of the patients and the sex of the patient. Okay, and then at the end, it is very easy. Step 1, step 2, step 3. It is like in former times. It's very easy to say if step 1, if step 1, the septal E wave is less than 6 centimeters, lateral is less than 7 or less than 6.5, patient has no diastolic dysfunction. And this is true also for HFpEF or reduced ejection fraction, or moderate reduced ejection fraction, doesn't matter. And at the other side of the schedule here, there's a diastolic dysfunction, absolutely sure, and it is more or less exactly that what we have seen for many years. And he has added now, as I told you before, the normal values. Let me just go through one example. This is here. This is an example. 80 years old, RCR infarction, bypass operation, paroxysmal atrial fibrillation after conversion to sinusrhythm, optical medical therapy, follow up 8 months. So in the first line, you see the first examination. Here, the second examination 8 months later. And what you can see is that the mitral regurgitation is there as before, and everything looks very similar. And you see the strain of the left ventricle, and you see that the ejection fraction parameters are very similar. It is, if you like, you can call it now a HFpEF, but it's a patient with coronary artery disease and bypass operation. And then we go through the mitral valve. And you see the first examination is this here, reduce E over A. And the second examination, 8 months later, is a high E and a lower E. And what is the very remarkable sign, and this is something which should be added to all your diagnostic facilities, is that there is an L wave. L wave, that means that this is severely diastolic dysfunction. This is only what we all know during diastole. If it is long enough, the diastole, then you have an L wave. This absolutely guarantees that there is a diastolic dysfunction. And so we go on, and you might believe that this is due to the mitral regurgitation, but look for the mitral regurgitation. It's a mixed mitral regurgitation, partly functional and partly organic. We should discuss it in another situation, and then we look for the lung vein flow. You must look for the lung vein flow to really quantify the mitral regurgitation. Everything is okay. You see a lung vein flow which is okay. And then we go through to the E over E prime. And you see here now, E prime is low, E prime and at the septum, and E prime is very high in the lateral wall. And this depends on the RCR infarction. This is true. One must know that with an infarction, you cannot use the tissue velocity imaging. And then you see what happens in the time between, and you see E prime goes a little bit higher, even in the infarcted area, and these values are also going high. This is strange because we do not really understand what happened to the patient. And I will show you what is the result, what is the reason for all that. He has a very strong A wave, or a very strong booster reaction throughout the time. The diastolic function of the left ventricle is worse than before, but throughout the time he has a very important atrial contraction booster function, so he needs his atrial contribution, and if he goes back to atrial fibrillation, it is terrible for this guy. So we can we see this booster function, and what is the final result of what we have seen and what I've tried to explain here is that you see that there is a severely increasing tricuspid regurgitation. At the same time, the pressure in the right ventricle is higher. So this is a decompensation in diastolic function with the same function in systole with the scar in that patient. So at the end, we can say that increasing diastolic dysfunction with all parameters can be seen very easily and very directly with all you can see, but we have no means to measure directly the left ventricular pressure. And then for ending my presentation here, again from Dr. Vogt, who is a genius in shear wave or in deformation imaging, they have written a new article, and this is the new technique which is evolving on the horizon. This is shear waves, and he really measures the millimeters of mercury in the left ventricle when he knows the pressure which to measure with on the right or left arm. And they got out with the shear wave technology, which is not on the market right now, but you are measuring the velocities inside the septum with 1,000 frames per second and more with a specific machine now. The images are not very good, but the Doppler data you get out of it are extremely good, and then you can really measure the pressures in the ventricle. If that really helps us to treat our patients, I do not know, but at least this is good. And I must end. I have nothing to summarize or take home message, but I believe that I could show you that it is a wonderful subject to talk about diastology, but not only in preserved ejection fraction, but for all our patients. Thank you so much.
Thank you very much, Wolfgang, for your excellent talk. We have learned very much.